dear colleagues and friends, a very good evening to everyone. We welcome you all in today's webinar on how to bring myopia management into your daily practice. Do you believe that vision without action is merely a dream? Action without vision just passes the time. But vision with action can change the world. In order to carry a positive action, we must develop here a positive vision and positive environment. And to create a positive environment, we need awareness, training, support from each one of you. As we know, more than 50% of world population will going to be myopic by end of 2050, whereas more than 1 billion people will come under high myopic category. So we, United Optometrists Forum in UAE and ZEISS Vision Care Middle East and Africa together take this step forward to create a global awareness on myopia management. We will going to have 3 sets of webinar: basics, intermediate, and advanced, where today is the first episode, basics. Before starting to the scientific program, now I would like to call upon Mr. Badouin Series, Managing Director of ZEISS Vision Care Middle East and Africa, to share a few words for today's event. Over to you, sir.
Over the past few months, Celine from our team, who I'm sure you all know by now, has connected with you and created a great network of professionals, ophthalmologists, optometrists, orthoptists, opticians, nurses, and you've all helped us understand the size of the myopia challenge in the region. And the fact that you are today more than 680 to have registered for this first webinar shows that you all care very much and have the same sense of responsibility. I would like to truly thank Optoverse and the UOF for organizing this series of webinars and allowing us to sponsor it. I wish you all a great educating and sharing time. Thank you and good evening.
Thank you, Mr. Badouin, for your nice introduction. Good evening, everyone. My name is Jabin Jaffer, optometrist at Medcare Eye Center. With this positive notes, let's start our scientific program for today's evening. I'd like to welcome our first speaker, Dr. Ehsan Gamo. Dr. Ehsan is an associate professor of optometry, Al Ahlia Aman University, Chief of Education Committee, World Council of Optometry. Dr. Ehsan will be talking about myopiazation, basic fundamentals of how myopia increases and its mechanisms. Dr. Ehsan, you can please take over. And for the audience, you can post your questions in the chat box.
Thank you, Jabin. Thank you, the organizers, for allowing me to speak about myopia management. This will be the first presentation in the series of the basic, intermediate, and advanced. As Swarna said, thank you, Swarna, for all the efforts you've done with Celine over the last few months. So going to be a little bit technical, this presentation, so you have to bear with me a little bit. We'll talk about myopization, the fundamentals. Just for my financial disclosures, I have no financial interest or relationships to disclose. And part of the material that I have here, I got it from IACL, as I am a fellow of IACL, and from the World Council of Optometry website, myopia website. So I just want to take advantage and read this quote from a physicist that I really love. He said that it was never easy to look into the future, but it is possible and we should not miss our chance. And as the Baudouin and Swarna said in the introduction, the future is myopia epidemic. So we need to take our chance now to manage it before we miss the train, as they say. Why myopia matters? It matters for so many things, but for me personally, as an educator, as a father, and a person who works with refugees, works with healthcare workers, works in less than ideal environments. For me, good health and well-being, one of the sustainable development goals of the United Nations, is very important. And we are all aware that poor eye health is linked to increased mortality, lower levels of well-being, and higher rates of depression. So we need to take care of that. And for me, children with vision impairment I've worked with them for so many years, and I know that they sadly have poorer educational outcomes and more likely to be excluded from schools. I've personally worked with some school teachers, school principals, and about 15 to 20% of students who leave schools actually because they have undetected, uncorrected refractive error, unfortunately. And speaking of refractive errors and myopia, this is a global snapshot from that seminal paper by the late Brian Holden uh, 20 years ago, almost, let's say like 10, 15% maximum of the people in the Middle East and North Africa uh, were myopic. We don't have so much data, neither in the Middle East nor in Africa. You can see most of the data is from China, as Budwan said, USA, of course, and certain other countries, but sadly not in our region. But we are aware, they were aware, and they were projecting the future, and we are seeing it right now. 20 years ago, almost quarter of the whole population of the planet Earth were myopic. We're now a little bit beyond 2020, and one third of the population is myopic, which is actually true. And in almost 20 years' time, half of the population will be myopic. So we can see this trajectory and this future epidemic, which we need to handle as eye care professionals. The question you probably would like to ask yourself, aren't we supposed as human beings supposed to be emmetropic? We know that the human eye is programmed to become emmetrope in the early childhood. And generally, our eyes maintain emmetropia even with advancing years. A little bit of hyperopia beyond the age of 50, but that's fine. And despite all of that and all the changes when you grow, even as a child and even as an adult, axial length and all the other dimensions usually keep growing, and especially the crystalline lens, as we advance, the thickness of the crystalline lens increase. Despite all of that, we still, emmetropes still stay emmetropes. So what was going on? Before we answer that, I just want to remind you a little bit of the refractive error status of children. Let's start at birth. The birth is the blue line. I wish, all right, if we have a laser pointer, that will be perfect. Good, here. So the blue line that you can see, it shows that children born are usually hyperopic in the range of around +2 diopters. By the age of 6 to 8 years, there is a shift towards myopia, but they become mainly emmetropic. Very, very rare myopia is seen by the age 6 to 8. So we expect a myopic shift from the +2 hyperopia to that plano emmetropic status by the age of 6. Mind you, though, these data are quite old and they are from British white children. Sadly, we do not have much data from other ethnicities. But another British white study that is more recent, and this is one for the younger children, it shows that most of the children are mainly within that +2 hyperopia, so a little bit average of around 1 ± 1.5. However, by the age of 14, 12, 13, you see a dramatic shift more towards myopia. Many children become emmetropic and they shift towards myopia. And this study has been done almost 10 years ago. So we can see how things have changed in the last 50 years. We are shifting more towards myopia, but still children are born hyperopic. We expect them to be emmetropic and stay that that status of emmetropia, becomes slightly myopic, but beyond the age of 6, not before that. So the very interesting BIBS study, and its aim was to chart the growth of components from 3 to 9 months. They used cyclorette keratometry ultrasonography, of course, overthrow closed lid. That study is an old one. It was available before having like ZEISS IOL master, for example. However, it's not easy at all to have a child sitting in front of IOL master, so they had to use an ultrasound over a lid. Anyway, regardless of the data, regardless of how they got it, the main outcome was axial length drives the growth of the eye and the change in the refractive error. So we need to focus on the axial length elongation or change when we think about myopia and refractive errors in general. This very complicated looking chart, don't worry about it. Basically, they are correlating changes in axial length with the change in the power and seeing which component in the eye is controlling whatever changes we are seeing in children. Corneal changes, corneal power are not correlated with a change in the refractive error at all. Changes in lens power do occur, but are not correlated with the change in the RX. The main driving force for change in the overall power of the eye is the change in axial length mainly. So we really need to consider that. All right? So emmetropization process moving from the hyperopia towards emmetropia is modulated by changes in axial length mainly. So the Olson study repeats what has been done on the children, but the younger ones, but now it's focusing on that age between 6 and 14. And with them, they compared emmetropes with the myopes, and simply the changes in the lens power matched the changes in the vitreous chamber depth in terms of the emmetropes. So we were fine with that. The main driving power was the change in the axial length itself. But the idea is there was change in axial length that was compensated by a change in lens power. See, we have 3 diopters changed in the lens power versus around 1 millimeter change in the vitreous. They compensated for each other. However, in the myopes, the story was different. They almost had a 2.5 diopters change in refractive error, a shift towards myopia. However, the change in the lens power couldn't match the change in the vitreous chamber depth. So basically, we are now more aware and sure that axial length change, mainly the vitreous chamber depth elongation, is deriving or driving the force for the development of myopia. And in terms of children who stayed emmetrope and who became myope, this is something we really need to be aware of. So by the age of 6, which is a very crucial age in terms of looking at myopia, you would expect those children who remained emmetrope to have a little bit of a hyperopic refractive error, being on the plus side, being fully emmetrope or a little bit to the minus side is very risky, and it drives the path for myopia. And by the age of 14, those who were not emmetrope, who were not hyperopic, slightly hyperopic, and they were a little bit on the myopic side, they developed up to 3 diopters of myopia, while those who were a little bit hyperop remained hyperop a little bit emmetrope, which is what we really need. So this is something to, as clinicians, to think about seriously. Okay. So we said 6 years of age is very important for us. Research also told us that the age of 10 is also important. That's why I call the slide the magical 10 and 6, to be honest with you. So let's chart the projections. So the blue are emmetropes. You would expect the emmetropes to have a little bit more vitreous chamber elongation beyond as they grow with age. However, they didn't increase that much. Actually, there was a shift, like a halt mechanism to keep them emmetrope. But the divergence came at the age of 10, which is quite interesting, to be honest with you. In terms of myopes, the opposite happened, yeah, and the vitreous chamber actually increased more than the projection, and that derived that more myopia that we saw in the previous slide. So we now know if you're becoming myope or you're becoming or staying emmetrope, that what will happen. But how is that happening? That we will see next. So in terms of gender, and I've reviewed so many studies, conflicting data, mainly they say females are more likely to be myopic. The difference is very small depending on age, other factors. Uh, we really can't say that males will be more myopic than females. That gender argument, let's keep it on the side for a bit. In terms of ethnicity, definitely so. Definitely, Asians, mainly East Asians, are more at risk of being myopic. Let's take Australia. This study has been done almost 10 years ago. At children of age of 12 of East Asian ethnicity, almost half of them were myopic, compared to less than 10% of those of Caucasian European background. So this is interesting. However, we need to look at something. So we know that uh, East Asian Australians have high myopia prevalence. However, if we look at their counterparts in another study, Chinese children in Singapore and Chinese children in Sydney, for example, Chinese children in Singapore had higher prevalence of myopia compared to their peers in Sydney. And this tells us that the location, rural versus urban, we know Singapore is very urbanized, densely packed cities. Sydney is a little bit more open. The environment there is different. They have programs to allow you to play outdoors. So there are some protective mechanisms, even if your ethnicity is playing a role. The environment is also supporting the change in prevalence, which is quite important. I would like to look at other factors from a perspective of India, and because India is very similar in terms of prevalence and factors like the Middle East and Africa, schooling type is important. So if you have heavy, intense schooling, it will put you more at risk of myopia. If your parents were myopic, you would expect to develop myopia. Having a higher socioeconomic status is not related to becoming myopic directly. It just means that you will be playing indoors more, you will have more digital devices, you will be living in an urban setting rather than a more rural setting, and dimming the light will also be a factor, and of course, shorter or longer TV games, PC watching. So use of digital devices at shorter distances put children also at risk of myopia development. So we need to ask ourselves also which theories are managing or behind this development of myopia. So many theories that have been discussed. First of all, the myopic defocus theory, first of all, will have a retinal blur. It will cause a myopic defocus, eye growth slows, and hyperopia is induced. That's one of the theories of how hyperopia happens. The minus lens, the hyperopic defocus theory, that there will be retinal blur, it will cause a hyperopic defocus, the eye will grow, and myopia will be induced. Just very simply put, and we can easily understand that. Good. The lag of accommodation theory has been looked at quite intensively and the relation between intense accommodation, intense need work, and development of myopia. And I've done my PhD in myopia development in adults back before the year 2010, let's say. I don't want to show how old I am, but the idea is back then, people were actually realizing that the lack of accommodation and the micro fluctuation in accommodation, they induce a little bit of myopia, but they are not the main reason for that axial elongation. It's actually the hyperopic blur that drives axial elongation. So, in summary, studies show us that reduced accommodative lag will introduce a modest result in myopia progression, and it shouldn't be our main concern. So we need to think about another factor. Hence, the hyperopic defocus theory that has gained popularity over the years, and many products have been developed based on this theory. So basically, you would expect myopic eyes to elongate, to display a prolate shape, and creating a relatively peripheral hyperopia. Animal studies have shown that in the periphery, the eye grows in response to this hyperopic blur. Potentially, conventional spectacle lenses will increase that hyperopic defocus and will increase the axial elongation. So, if you place a conventional spherical or spherical cylindrical lens in front of a myopic patient eye, you'll create that hyperopic defocus in the periphery of the retina, pushing the eye to grow further. However, if you induce myopic defocus in the periphery, this will halt the progression of myopia. And this is the basis for so many new optical correction strategies that we are seeing now in the markets. So I was watching The Hobbit yesterday, and I thought I should include this slide. Basically, outdoor activity is a protective mechanism against myopia development. I need you to pay so much attention to this. As clinicians, we need to give accurate advice to our patients, and protection is better than cure, and it really happens with outdoor activity. Research has shown that children who play outdoors when they are young, before the age of 6, it creates some sort of protective mechanism against development of myopia, or it will delay the development. However, research has shown it has less effect against myopia progression. So once that 6 years of age mark shows shift toward myopia, really outdoor activity cannot do much, as if you, for example, expose your children to more outdoor activities, with almost like 10 hours per week, okay? So children should be encouraged to spend at least 10, if more than 11 hours per week outdoors. Why is this happening? We're not quite sure yet. So we need further studies on that. They believe the reduced image blur, the reduction in the image blur might actually drive that. The greater viewing distances are also helping in halting the myopia progression. Perhaps increase in dopamine release, and it has been correlated with other positive changes in the human body. Still, studies are outgoing. They also say that the protective component of the sunlight itself, though it sounds very vague, I know, but there is an effect, a documented effect, that children who play outdoors before developing myopia create some sort of protective mechanism. I only have a couple of slides, so I think I'm a little bit earlier than what I'm supposed to do, but we need a couple of minutes to focus on this theory. Has been recently published, and actually one of the ophthalmic lenses that are released in the are based on this contrast theory. The contrast theory for myopia, it tells us that high retinal contrast leads to overstimulation of the retina. This overstimulation sends signals to the eye to continue growing. Interesting, right? Low retinal contrast, on the other hand, signals the eye slow or stop growing. So if you look at the pictures down here, this is the original picture. In this picture, we have a reduced contrast. In this, but see, it's not blurred. You can see details, but the contrast is lower. In this image, we see blur. And this blur will actually increase or drive the eye to grow. Remember, we talked about hyperopic blur, and it's now driving the eye to grow. Here it's something different. Blur is different from contrast. Contrast, you can still see details, but at a lower quality. However, if you combine blur and reduced contrast, then you are actually accelerating the eye growth more and more and more. So, as we have said before, and we all know, near work is well known to be associated with myopia progression. How? Still, we don't know the case. The hyperopic blur theory that we discussed a little bit earlier drives that. However, the contrast theory suggests that this near work disrupts emmetropization by presenting a large amount of high contrast information across the retina. And it's an interesting theory. It just reminds me of the infrared light for myopia management that we're seeing lately. We still need more research on that, so we need to be careful when interpreting literature at the moment. Okay. So, Swarna, and Jabin, if you allow me, I would like just to summarize what we've been through. Emmetropization is an active process. It's a homeostatic control. We need to control our homeostasis. We are expected to be emmetrope. No child should be myopic. Something is happening that is disrupting the emmetropization process because the retina is able to detect signs of defocus and controls eye growth. Myopic versus hyperopic defocus. If I want you to just remember one point about the theories of myopia development, it's the hyperopic defocus theory that has been shown to actually be one of the main key roles in pushing the axial length to grow, hence the increase in myopia. It seems that chemical signals must, and we know that, must pass from the retina through the choroid to reach the sclera. These chemical signals, especially at the choroid level, they have like some sort of growth modulating molecules that respond to visual conditions. So if you trigger those growth modulating molecules, it will increase the growth of the eye. So this is something very important for us to understand. So basically, if we want to summarize, playing outdoor before the age of 6, before the onset of myopia, creates a protective mechanism against myopia development. Once there's an onset of myopia, playing outdoor plays a very reduced role in controlling the progression. Slight changes in accommodation, mainly lack of accommodation, might play a small role, but it's not the major player in myopia development. So we need to consider that very carefully. And that's it. These are my references. If you'd like to take a screenshot of these, I know the text might be a little bit small, but can you imagine those less than 30 slides take so much time to read? And thank you so much for allowing me to share my little bit of experience on myopia. Thank you so much.
Thank you, Dr. Yazan. That was an excellent speech, as usual. Now we understand what is myopization and its importance of understanding the facts before starting a myopia clinic. So please, attendees, if you have any questions, you can write them in the chat. We will try to answer them during the panel session. Moving forward, so I would like to call our second speaker, Dr. Najla Hassan Ali. Sorry if I do not pronounce very well, to talk about refraction for myopic children. Dr. Najla is a specialist ophthalmologist at Dubai Hospital about pediatric and strabismus clinic. An accurate refraction is a hallmark of best practice in myopia management. So, however, refraction in children can present particular challenges. Dr. Najla will give us the most accurate techniques and tips. Dr. Najla, moving towards you, you can take over, please.
Thank you, Celine. So good evening, everyone. I'm honored to be part of this amazing webinar. And tonight I will talk about refraction in myopic children. First, I have no financial interest or relationship to disclose. So why myopia is important? Because it's very common. Daily in my clinic, half of the patients I'm seeing in the clinic are myopic. So if I talk briefly about the epidemiology, the prevalence rate of myopia in the United States has been reported as high as 80 to 90%. 66, sorry, I cannot see the slide. Okay, 66% of the patient with myopia has less than 2 diopter of myopia, and 95% of myopic patients have less than 6 diopter. Lower prevalence rate were found in African American children with a 6.6%, followed by Caucasian children with a prevalence of 4.4. So we always tell the parent and we educate teacher in the school, if the child have any symptoms that tell us that he's having a refractive error, like a blinking, tearing, he complain he cannot see, or the mother notice anything in her preschool child, she should bring him for examination earlier. But vision screening is recommended by the American Academy of Ophthalmology to start by the age of 3 and occur each year at age 4 and 5. And after age of 5, it's recommended to screen at least every 1 to 2 years. So the pediatric eye examination, each development level in children will require a different approach for the examination, but with a proper preparation and a positive attitude, the ophthalmologist can find the examination of pediatric patient to be both enjoyable and rewarding. So the examination starts since the patient enters the room. You will start by observing the patient visual behavior. You will try to check his feature. Is he having any syndrome? You will start to observe, is he looking around? So that's why you need to prepare your clinic with toys to distract him and check if he's looking to the toys. Also by taking a full history, asking about myopia in the sibling, in the parents, in the mother, in the cousins. Also by observing if there is any abnormal head tilt, which can tell us about a refraction. So when you start examining the child, always try to be in the level of the child. Try to have an eye contact with the child and try to show him some toys. There is some techniques you can ask him to sit in the mother lap so he will feel comfortable and he will not get anxious and start crying. So for the visual acuity assessment, the visual acuity assessment will depend on two factors. The first factor is the age of the child. The second is how cooperative is the child. So if we will say that since birth, there is some technique that can tell us if this child is able to see, is there any vision? It will not tell us accurate how is his visual acuity, but it can give us an idea. For example, at birth, if you object a light to a child, he can start to blink. So we need to put in our mind if the child is a preterm, because this reflex will develop after 30 weeks of gestation. For the fix and follow, the child can start fix and follow after the age of 3 months. So if we will examine a child in our clinic from the age of 3 months to 2 years, so we can go for a fixation preference. What is the fixation preference? We start by observing the child behavior when we occlude one eye. So we can see as in this picture, we try to occlude the first eye, you notice that the child is happy. When you try to occlude the second eye, you notice that the child is anxious, he's crying. That means you are occluding the better seeing eye. Because if we have similar visual acuity, the child will not feel a difference. But if you are occluding the better seeing eye, you will notice that the child will get anxious and he will not. Then we will start to bring a toys or a light, and we will move this object in front of the eye in a pursuit eye movement. We need to check a fixation. We need to check three things. The first is the central. You need to make sure that the light reflex is central in the cornea. Second, it should be steady. That means there should be no abnormal eye movement, no nystagmus, nothing weird that you are noticing. Third, it should be maintained. Mean when you remove the occlusion, you can find that the child is maintaining fixation. So for central and steady, I'm checking a monocular vision. But when I do a maintain, it is a binocular vision check. Then we go for a child who are in a preschool from 2 years to 5 years. We can use some chart like LEA, like an HOTV, like Allen chart. It's more like a pointing and matching, because in this age we can have children who are shy and not very cooperative. They don't know the letters. Sometimes they don't know that this is an apple or this is a circle. So it's more like a pointing and matching. So this is a table which shows us that the mean visual acuity by 2.5 years and 3 years, he should have at least by the HOTV 20 to 30. At 4 years, he should have a 20 to 25. And at 5 years, should have at least 20 to 20. Then we have an alternative method of visual acuity assessment in a pre-verbal children. Like we can see in the first image, there is a pillar card. Here, it can give us an estimate of a visual acuity. Usually by 2 years, normally to have at least 20 to 30. The VEP, which is a visual evoked potential, it has 97% sensitivity in detecting a visual defect, and it's also an effective method to know the function, how good is the optic nerve functioning. Another thing is that we have the optokinetic nystagmus can also estimate the visual acuity. Then we go to the children who are 5 years old and more. They are in school age, it is easier. We can go for a Snellen chart. We can check the visual acuity by the autoref and by a manifest refraction. We check if the child is improving or he's not improving. Then I continue my examination. I start by a red reflex. Red reflex is very important. It should be done in a semi-dark room. And we are comparing the red reflex clarity and similarity between both eyes. Can give us an idea if the child having cataract, which can induce a refractive error, if the child has any retinal problem that can induce a refractive error, and a Bruckner test, which can give us an idea if there is any squint that and this child that is the child having any refractive error. Interior segment examination, it will be done by a slit lamp if the child is able to sit. If the child is not able to sit, we have the portable slit lamp, or we can use the lens 28 with the indirect ophthalmoscope. It's very important because ptosis in the eyelid can induce a refractive error. Corneal opacity can induce a refractive error. Infection sometimes can decrease the visual acuity. And if there is any pupil which are not regular and round or abnormality. Checking IOP is also important, especially that congenital glaucoma can present with a high myopia. So we check the IOP by a tonopen, or we can use an eye care also. Now I go to the most important step, cycloplegic refraction. We all know that there is a relationship between accommodative and a convergent. So when we go for a cycloplegic refraction, we are uncover any hidden optical aberration. We are uncover if there is any hidden hyperop. We are uncover if the patient having a accommodative spasm. Accommodative spasm is very common nowadays with the kids sitting in front of the iPads and doing a near activity for a very prolonged time. So to prescribe the right glasses and not giving the child over minus, it's very important. So how we do a cycloplegic refraction? The most commonly medicine used, it's a cyclopentolate 1%. If we have an infant, we can use a 0.5% of a cyclopentolate. Usually we combine it with a dilating drug like a tropicamide. So what we do, we are applying 2 drops, between them 5 minutes apart, and then we wait for a 30 to 60 minutes. The most important to know that there is a cycloplegic effect. That means the child's pupil is not only dilated, but he is not able to read also. Then we go for a retinoscopy. There is another medicine which is not used a lot nowadays. It is an atropine. The technique is that we can give the parent the drops, the bottle at home. They use it 3 days, 3 times a day for 3 days, and they come in the 4th day to the clinic to do a retinoscopy. Now, the side effect of the medicine, the cyclopentolate and atropine, both they can cause hypersensitivity reaction, they can cause conjunctivitis, they can cause lid edema and reaction. But atropine have more systemic side effects. It can cause flushing of the face, it can cause dry mouth, it can cause dizziness. Also, cyclopentolate can cause dizziness and nausea, and it has a side effect. Another thing is that the action of cyclopentolate will stay only for 24 hours. The action of atropine can stay up to 1 week and sometimes more. So it's not comfortable for kids, especially if they are going to school and they have exams. It's not very comfortable for them. Then we go with a fundus examination. For the fundus examination, it's very important for kids, especially if they are high myopic, to check if there is any peripheral tears, if there is any peripheral degeneration, and to which can induce a retinal detachment. So full examination of the fundus is recommended. Peripheral examination with indentation is recommended for treatment. So if I will go to summarize the indication for cycloplegic refraction, if you have a young, if you have a hyperop, if you have high minus in manifest refraction, if you are having a child who's coming with a vision 1, but he keeps complaining of blurry of vision, hearing when reading, eye strain, please do cycloplegic refraction. If it's the first visit in your clinic, always do cycloplegic refraction. This is a table which will summarize a guideline how to correct myopia. So here, in case we don't have a squint, because if we have a squint, it's a different case. If we don't have squint, if we have isometropia, similar refractive error in both eyes, if the child age less than 1, then if it's -5 or more, you have to always to correct. If the child age 1 to less than 2 years, if it's -4 or more, you have to correct. If the child age between 2 to 3, if it's starting from -3, you have to correct the child. If it's 3 to less than 4 years, even if you have 2.5 myop in the manifest, you have to correct. So you always give the manifest refraction in case we don't have a squint, and you give the manifest refraction with the best vision. If the child having anisometropia, and he is myopic, different in refractive between both eyes, if the child less than 1 year, if it's -4 or more, you have to give the correction. If the child is 1 to 3 years, if it's -3 or more, you have to give the correction. If the child age 3 and less than 4, if it's -2.5 or more, you have to correct. Another thing I would like to say that whenever it is your the child first visit to your clinic, and we are correcting the myopia, we need to follow the child earlier. We need to follow the child after 3 months to make sure that his visual acuity is reaching 1 and he didn't develop amblyopia. Okay, so I think that's all for today. Already Dr. Yazan said about prevention of myopia and how outdoor activities have shown and decreased the near activities like sitting on the iPad for a prolonged time can control myopia progression. Thank you so much.
Thank you, Doctor, for your enlightening lecture, Dr. Najla. You have clarified and addressed all of the fundamental refraction techniques for the myopia children. Now, I'd like to call Ms. Fahima Carolina, our third and last speaker of this evening. Fahima is an optometrist at Sheikh Khalifa Medical City, Abu Dhabi. She'll be sharing with binocular vision and myopia control. As we all know, binocular vision assessment adds so much more to our clinical practice, ensuring that our patient not only having good visual acuity, but can also see comfortably for near. Like to hear more about the same in detail from Ms. Fahima. Please commence your speech, as audience can post your questions in the chat box. Fahima, over to you.
Thank you, Jabin, for the introduction. Let me just get my presentation up. Okay. Excellent. So I want to express my heartfelt gratitude to the team for inviting me to present tonight. It's truly an honor to be a part of an event that values the contribution of orthoptists in myopia control. Your inclusivity is commendable, and I'm excited to share insights on this important topic. So a little about me. Hello, I'm Fahima, an orthoptist with a career spanning Moorfields Eye Hospital in London, Dubai, and now at SKMC Hospital in Abu Dhabi. I am co-chair of the Optometry and Orthoptics Working Group for the Emirates Society of Ophthalmology, alongside our host today, Kamal, and I am delighted to be here. I have no financial interest or relation with any of the products mentioned in this talk. Now, to start off with, I want you all to ask yourself a question. How much does the BV test matter in myopia management? Just take a minute and just think, how much are you really considering the binocular function in patients you're treating? How far are you taking the information on the binocular status on the child in front of you? We don't really need too long to ponder, do we? I'm sure the answers come to you quickly. So for a little bit of background, typically we have orthoptists carrying out vision tests in children and doing their binocular vision assessment, and optometrists doing the refraction and being involved in the further talks with the physician regarding myopia management. Now, to do a little bit of background research myself, I asked some of my orthoptist friends from various facilities locally within the region and internationally, and from facilities that are actively prescribing for myopia control. I wanted to ask them to understand how far their part in the decisions go. Generally, what I found was that orthoptists were sticking to doing their vision tests on the patient in front of them and their basic binocular vision tests. They then passed the patient on and didn't really get involved with the myopia management side of things. Of course, if they noticed differences from one visit to the next, they would then highlight this, but that is it. That's as far as they would go. And on the other side, I asked some optometrists their understanding of what considerations you should make regarding binocular vision and myopia management, or if there's any BV disorders they were aware of that affects myopia management. And you must have guessed it, the majority mentioned accommodative lag and stopped there. Now, although there is some research looking into the effect of accommodative lag and myopia management, there is so much more. And of course, I'm going to come on to accommodative lag later on, but there's so much more to consider in your plans. That's what I'm going to make clear to you over the next 30 minutes. By the end of this presentation, you will have a deeper understanding of the binocular vision factors contributing to myopia and strategies for effective myopia management treatment for the future. Now, here's how we'll proceed. First, we're going to dive into what disorders of binocular vision may affect myopia management, understand how to test for these. Then finally, we'll discuss practical strategies for myopia control that you can implement in your assessment. Remember, this part of the series is the basics, so I won't get too technical and I will only discuss considerations. By far, I will not be able to suggest to you what myopia control method to use for what BV disorder, but you will decide that based on your assessment and with your understanding of the influences after this talk. So let's jump into it. Let's be clear and let's start. First things first, apart from accommodative lag, we're also considering the following: esophoria, intermittent exotropia, and amblyopia. So really look out for these. Esophoria is known to be associated with the development and progression of myopia. High degrees of myopia present at birth can lead to an esotropia with early onset in childhood, where the infant tries to view objects at a far point very close to his eyes to use his optimum visual acuity. Esophoria, as we know, at near can be a risk factor for myopia development and progression. And on the other side, correction of myopia can decompensate an esophoria. So just for a quick recap, esophoria is a latent phoria of the eye relaxing in an inward state. We use the alternate cover test to diagnose an esophoria and find the eyes move out to fix when we do that. A myopic esotropia is also known as a heavy eye syndrome. It usually presents later on in early adulthood, usually greater than -9, usually in patients with greater than -9 diopters of myopia. We can also notice esotropia in lower myopes, but this is usually a decompensated esophoria. Now, with an intermittent exotropia, it's an exophoria which decompensates and becomes manifest at times. This can be related to distance, tiredness, brightness in bright sunlight. We use the alternate cover test to look for an exophoria, and what we'll find is that the eye moves into fix. Another thing when we do our alternate cover test is we want to look at the recovery. So when we're doing alternate cover test, which I'm going to talk a little bit more about in a second, we want to see how quickly the eyes cover to fix and work together, or whether they stay in a manifest exotropic state. Sometimes the exophoria can increase in dissociation, and it can be an intermittent distance exotropia we're looking for, a non-specific convergence weakness, a non-specific or a convergence weakness. Factors, a population-based study showed that 46.5% of children with intermittent XT were myopic by 10 years of age, and more than 90% were myopic by 20 years. Considering the high prevalence of myopia, attention should really be given to myopia progression in children with intermittent XT. Now, so cover test and alternate cover test. So basic first thing I want you to do if you're going to do a binocular vision test is a cover test. So you're looking for a manifest squint, okay? I think all of us know how to do it, but how to do it well. We want to test it with the glasses and without the glasses, just to see the effect that it's having, what the effect the prescription that we are giving is having, okay? With the cover test, we're going to cover one eye, and I want you to look at the uncovered eye to see the movement. Is there any movement? Is it moving out to fix? When in that case, it'll be an esotropia. Is it moving into fix? In that case, it would be an exotropia. And you can move and then move the cover over, and then you cover the opposite eye, see if there's a movement. If it's not, this way you'll be able to know if there is a squint, a manifest squint, if it's in one eye or if it alternates. And then an alternate cover test is what we're doing to look for a latent phoria. So we cover one eye and we quickly switch to the other eye. It's important that we always have a good detailed target. So at near, we try to get them to accommodate and look at a detailed target. In distance, we're making sure they're looking in the same place. They're not really, their fixation's not really everywhere. They're looking at one place. With children, obviously, you just want to make the pictures go quick or the target go quick so that they stay focused in the distance. And we want to give them enough time to fix on the target. So we're going to go quick between the two eyes, but we give them time to fix. Quick between the two eyes, give them time to fix. And we're really looking at any movement, and then again, the recovery. So if we've got an exophoria, we're looking at the movement, and then when we take the cover away, okay, does the eye quickly come in? Does the eye take a little bit of time to come in? Does the patient need to blink and the eye comes in? Does the patient need to refocus and the eye comes in? Or does the eye just not come in until later? It stays manifest. This gives you a really good idea of how well the patient is controlling their latent phoria. So another thing we really need to take into consideration is convergence. So just a little recap, convergence is the ability to bring both eyes together towards the nose. 1/3 of convergence relates to the tonic, fusional, and proximal convergence. 2/3 of the convergence relates to accommodation. So as we all know, accommodation is the ability to focus your eyes on close print. Now you can measure your convergence and your accommodation in free space. So with convergence, you just have any target and you bring it close to the nose and you just see whether the patient can bring their eyes together at the same time. Or you can use what we call it RAF rule, which is like a ruler that just sits on the cheekbones as far, and you bring the target close. It's got a little dot and a line through it. You bring it close to the nose and you can measure how far they can converge to. And the accommodation, same thing, just have a little print of writing or text and just bring it close and see to what point they can keep it clear. Now, it's suggested that a pre-myope may show higher ACA ratios. The effect of managing these disorders on myopia development has not yet been defined, but it's something that the research is really looking into. So ACA ratio is the measurement of changes in accommodative convergence in prism diopters induced when the patient exerts or relaxes one diopter of accommodation. We measure it using the gradient or the heterophoria method, which I will come to shortly. Studies have found that the ACA ratio is elevated prior to myopia onset and as early as 4 years prior to myopia onset. The ACA ratio has been found to reach its peak at myopia onset and remain both stable and raised through at least 5 years after myopia onset, which is actually a very significant number, and it's very important to take this into consideration. So a few more numbers here. In non-myopic children, having a response ACA ratio of 5.84 prism diopters or more elevated the risk of development of myopia within 1 year by 22.5 times. And in a subsample of children without myopia who had refractive errors less than plus 0.7 diopters, having a response ACO ratio of 5.84 or more elevated the risk of development of myopia within 1 year by 3.21 times. So we really need to talk about this, and this is where myopia control is very important. Myopia management is very important as well. Try and bring these numbers down. Now, so to measure ACA ratio, as I mentioned, there are two methods. You've got your heterophoria method and the gradient method. Heterophoria method is the difference in deviation between the distance phoria and the near phoria. And in this method, you take into account the IPD. So it's the IPD plus near minus distance. Super easy. And the gradient method can be used with concave lenses at 6 meters or convex lenses at 3 meters. So what we want to do is we want to measure prism cover test. Whether we're going to do it at distance or near, it's up to you. And the way we measure, the way we measure it is we calculate with accommodation minus without accommodation, and then we divide it by the strength of lens. So typically I usually do it with +3 lenses. So I'll always divide it by 3 because I find that easiest. Okay, so coming to the exciting topic, which there's not much to say about, I'm afraid. It's a little bit of an anticlimax. So accommodative lag. It is suggested that accommodative lag plays a role in myopia progression, but it is not yet fully understood. So there's a widespread belief that accommodative lag is involved in myopia, but there's so little evidence to support this proposition. Alternatively, and this is a good study, a 5-year prospective study of 268 adults between 25 and 35 years of age found that lower accommodative lag was associated with myopia progression, which is interesting. So I think the early bits of binocular vision research, the early bits of research into myopia management linking binocular vision was accommodative lag, which is why I think there is so much focus on accommodative lag. But really, for me, I really want to portray a message that there's more we need to look at. And I really hope you take that away with you as well. So why is it important to ascertain the binocular vision status? The real answer to that is just that we need to know how much we're affecting a patient by giving them different treatment types, okay? So we want to know, do they have aphoria? Are we going to make it manifest? Is it going to affect their vision? Is it going to affect their control? Is it they're going to maybe might end up having amblyopia because they might end up in a manifest deviation, anything like that? We really, really want to look at that. But there's little examples like greater myopia control effects with progressive spectacles were reported in children with larger lags of accommodation and near esophoria, So it's something you really want to think about when you're thinking about the type of treatment for myopia management you're going to prescribe. So intermittent exotropia, given their differences from normal children, binocular vision is more critical for children with intermittent exotropia. If these individuals lose maintenance of vision, they could manifest in exotropia. And that wouldn't be good, would it? Now, when we're looking at glasses versus contact lenses, in theory, as an orthoptist, we don't see a significant difference when comparing treating the visual acuity with glasses or contact lenses. So we're not seeing a big difference in the effect it's having on esophoria or an exophoria. But what we really need to think about when it comes to glasses is Prentice's rule. So just a quick recap to remind you, when the optical center of the lens is aligned correctly, there's no prism effect. If a highly myopic lens is decentered a little, or the patient looks in a different direction, this can induce a prism. So if a myopic lens was decentered temporally, it would give a base-in effect. If the myopic lens was decentered nasally, it would give a base-out effect. Now, this is obviously talking just about single vision lenses. And we just want to make sure we're not having that effect, especially if someone has a very high myopic lens. We want to make sure that we're not going to induce or make phoria worse by inducing a prism. It's just a consideration we need to have. Now, I tried to look into a few papers and a bit of the research out there that looks at some of the different types of myopia management methods and sees how much of an effect it has on the squint. And again, I can't stress this enough, there's not enough research out there. Really need to do more work on this. So what I found was when we're looking at progressive addition spectacle lenses, children with esophoria and single vision spectacle control groups were seen to progress quicker. So that's something, we might need to consider, we might need to think about. And larger baseline accommodative lag. So children with larger baseline accommodative lag showed statistically greater treatment effect with progressive addition spectacle lenses. With multifocal soft contact lenses, as currently available, multifocal soft contacts can sometimes reduce the quality of vision. So what we want to do is we just want to really make sure that you're testing the vision and you're making sure you're monitoring the quality of vision. Of course, if it's only affecting it by like half a line, okay, we can continue with that treatment method. But if it's making a big difference, then we visual acuity always takes the priority, I'm afraid, in these cases. Some research showed that children wearing multifocal soft contact lenses exhibited reduced accommodative responses and more exophoria, increasingly higher accommodative demands than with single vision contact lenses. Center distance multifocal soft contact lenses increase near exophoria and provide near plus. I guess this is beneficial for ESO-related disorders, but not exo-related or accommodative excess. Some research into orthokeratology showed that it induced more exophoria and less lag of accommodation compared to soft single vision contact lenses. Children with lower baseline accommodative amplitude have shown a greater myopia control response to ortho-K compared to normal accommodators. So I think I've just finished off a little bit early as well. But my conclusion and my take-home message really is it's still in the early stages of research for myopia treatment effects on binocular vision. Lots more research to come. For now, I would say it's important for you just to keep checking the BV status, treat the patient holistically. I think there needs to be more of orthoptics / optometry input and working together on this as well. Because what we don't want is these things just get not considered now, and then 5-10 years down the line, it's like, oh, we needed to do this, or we should have done this. Let's start we're thinking, because now we know the theories, okay, this could affect this and this could affect this. But if we could really work together on this, really think about the patient as a whole, the patient were, you know, their vision, their binocular status, their refraction, and then take myopia management into account, I think we could really promote better vision and eye comfort. Thank you for having me again. I have to say again, it's honestly been a pleasure to be invited, and I'm so happy that as an orthoptist I was invited to talk on myopia management. I'm still going to push to have more orthoptic input in this, but also as optometrists, you know, you guys can do your due diligence as well with the BV testing as well, and looking at the BV reports. And here are some references. So thank you again.
Thank you so much, Fahima. To be honest, when we were working on this series of webinar with Yazan, I definitely thought that binocular vision was a need, especially in the region. As you know, I'm French, and in French we have orthoptist and visual treatment. I mean, therapy is really a need. I did some, my kids are over it, and it's really making a difference. So not only in myopia management, but in general, having really binocular vision interest is a need, is a must. So I'm really happy that you accept to join this webinar.
Thank you very much, Celine.
Yeah, to talk about that, and I believe it's maybe just the beginning.
I agree.
So
definitely.
I might have to call you again, but that was really a fantastic speech, and yeah, it really added, I guess, value to our practitioners. To be honest, I even think that this basic level may be already too high. And maybe that we have to do a full session about binocular vision and all measurements. So I really want to thank you. So I want to thank you, everyone, all speakers. It was actually a short time, but it's great because we don't want to take too much of your time. It's only Monday. We've got a busy week coming. I'm just going to take a few minutes to talk about MyoCare. Just to give you some updates, because I believe you all already know the product, have been talking about it for such a long time. But yes, could you please just share the video, Swarna?
Seeing the world through the eyes of a child. Fun. Adventure. Friendship. Caring. A large portion of what they learn and experience occurs through their eyes. That's why every little detail of every single moment counts. The prevalence of myopia progression is becoming a serious problem, especially in Asia. ZEISS has been serving the Asian market with myopia research and cutting-edge lens solutions in the management of myopia for over 20 years. Leading the pursuit to manage myopia progression. With the increasing risk of juvenile and high myopia in Europe, we bring our latest lens innovation to the rest of the world. ZEISS MyoCare lenses. Our story begins with a circle, believed to be a powerful and magical shape. Building on our continued innovation in managing myopia progression and using our scientific expertise, we developed a new and improved solution to tackle this global issue. Inspired by myopia management solutions like soft contact lenses and orthokeratology treatment, ZEISS MyoCare lenses incorporate cylindrical annular refractive elements in the lens design. It incorporates a central clear zone, enabling clear and sharp vision for a straight-ahead line of sight, and a peripheral functional zone formed with annular cylinders that are equally distributed on the lens, with a precise width, height, and spacing. Light bundles passing through the care elements of its ZEISS MyoCare lens are refracted to form a caustic area with an extended focus range that converges to a minimal waste and diverges again. The functional zone induces alternating simultaneous blur and myopic correction zones on the peripheral retina, with the aim to slow down the progression of myopia. Because eyes are constantly moving, ZEISS incorporates clear focus design, a unique optimized back surface aimed at minimizing the hyperopic defocus in order to maintain the patient's refractive correction, as well as the intended myopic defocus for all gaze directions. Ongoing multi-center clinical trials with leading medical institutes and hospitals are being conducted to ensure comprehensive and representative results. Early results have shown that MyoCare lenses can effectively slow down children's myopia progression, keeping in mind that the lenses offer great wearability and comfort. For children presenting with signs of myopia progression, the best moment to prescribe ZEISS MyoCare is now, because every diopter matters.
Thank you, Swarna. I'm now going to share my screen very quickly. Okay. Okay, so cannot see it here, but let's go there. I hope you can see it. I just want to make some updates about availabilities and prices. So this lens is available right now in UAE, Qatar, Lebanon. It's going to be available in Nigeria, and very soon in Saudi and Bahrain, Oman, other countries in Middle East. As you, I hope, already know, we have two types of MyoCare. We have a MyoCare hard design, which is prescribed up to 9 years old, and we have a MyoCare soft design from 10 years old, okay? The difference is the myopic defocus value and the size of the central zone. Dr. Yazan said it just before. We are saying that the axial length elongation is a biological reaction from the hyperopic defocus on the peripheral part of the retina. And this is involved due to the aberrations on a single vision lens. So what is creating MyoCare is actually a myopic defocus in front of the retina, so that a stop signal is going to be sent to the brain about the axial lens elongation. Okay, so it's working. The only thing is that we have two designs, two values of myopic defocus, plus 4.6 for the hard design and plus 3.8 for the soft design. The size of the central zone is going to be different as well. 7 millimeter for the hard design, 9 millimeter for the soft design. So what I just want to say here is that you have two designs. The option to prescribe it is only an age related. Okay. For now, for the MyoCare hard design, you have 1.5, 1.59, 1.6, plano to -6, with a cylinder of 4 up to 6 in 1.59. You have two different coatings, anti-reflecting coatings available, DuraVision Kids, with an anti-scratch coating very strong, and DuraVision Platinum, okay, the one you know. MyoCare soft design for now is only available in 1.59, but no words. You have the prices here, it's in dirham. What is really important for you to know is that in this price, you have a specific warranty because this is a treatment, okay? So you have a power change warranty. If the correction is changing, we change the lens for free up to 9 months, okay? Non-adaptation, if there is any non-adaptation, we change and we put single vision lenses. Scratches, cracks, 70% discount on first replacement, 50% discount on second replacement up to 1 year. Cutting damage, even if cutting damage, replace the lens. This is very important because we want to show you that this is a treatment with a follow-up, okay? To explain to your patient that this is a treatment which is involving a follow-up, we have worked on different marketing materials. We have now a patient leaflet where we explain everything, what is myopia, what to do if your child is having myopia, that LASIK is not the answer. It's not because they can have LASIK once they are an adult, that retina is not going to be damaged due to a high myopia. So we explain everything in this leaflet. Then you have a display with a lens. Okay, so you can show exactly what it does look. It's very discreet, very aesthetic. And all the results about comfort, near distance, far distance, everything from our last studies is really good. All of the children, 240 exactly, adapted within 1 day, okay? So if you had a previous experience with a progressive lens and you had problems about adaptation, this lens is totally different. Then we do a follow-up booklet. Every time we are going to dispense myopia in an optical store, the optician is going to give a booklet. In that booklet, we have explanation about myopia, about what to do about the different techniques of myopia management. Then you have different pages where you write each follow-up, what is the evolution of the myopia, what type of lenses, PD, height, everything in written, and they can even do their own curves about refraction, okay, and about axial length. So it's really a follow-up. And we have a last tool, which is for the one prescribing. If you want to remember, we have a post-it that you can stuck on the prescription. You just pick the myopia that you want. You can write down the next appointment follow-up. And so the optician will know exactly what you want. There are not that many lenses available, but if you really want to prescribe ZEISS, we definitely can provide you some of those post-its. I believe you all know me. If you do not, I'm on LinkedIn. If you need any of this marketing materials, please just reach me out. Say you can even write it on the chat and I will send you some. Okay, so that's it for myocare. That wasn't the main topic of this evening. I'm going to stop sharing my screen and we are going to start our panel session.
Thanks, Ms. Celine, for that wonderful information. It helped us a lot. So, and today we have covered few basic topics in myopia management, which will help optometrists, practitioners, and who is managing with myopia. It helped a lot. So now it's time to start the panel discussion. I'd like to call Dr. Ezan, Dr. Najla, Ms. Fahima, and Mr. Arnab Banerjee to join the panel. Before the panel, I'd like to introduce Mr. Arnab Banerjee. He's a senior optometrist, M-Opto, orthoptist from Aravind Eye Hospital, in charge of Binocular Vision Department, Shankar Netralaya, Kolkata, 2013 to 22. He's a program coordinator, HOD of Optometry Department, NSHM Knowledge Campus, Kolkata. Please welcome Mr. Arnab.
Thank you. Thank you.
Hello, welcome everyone again in the panel discussion, and such a wonderful evening, and all the speaker wonderful talk. So great round of applause for everyone. So we can start our panel discussion with my first question to Dr. Yazan. What are the factors that drive myopia onset and progression in the Middle East and including GCC countries also?
Very interesting question. I like it. Okay, you are now in Dubai, right? You've been living there for quite a few years. and I bet you have children. I've met Fahima's children, and I've seen the struggle of letting them go out and play and enjoy themselves. It's too sunny, too hot, too humid, too everything. So I think staying indoors for quite a long period, though most of our countries have almost 36, 5 days a year of sun, is quite uh, incomprehensible, may I say. The idea is we have very short amount of time that we allow children to go out comfortably to play outside is one of the main reasons. I remember growing in the Gulf back in the late 80s, early 90s. Most of us used to stay indoors, fixed to the Cartoon Network TV most of the day in the weekends, or going from school to returning back home and opening our books because we used to go to international schools and the burden of studying is really high on us and they expect so much from us. So basically, studying, near work, less time outdoors, and less exposure to sunshine. Remember when we talked about the outdoor play, the sun itself, the release of dopamine is one of the factors. If you think about it from another field in medicine, many women in the Middle East and the Gulf region suffer from osteoporosis and calcium deficiency. Why? They're not exposed to the sun that much. So vitamins A and D are not playing that role in with the calcium that they drink with the milk. And if you look at milk cartons 30, 40 years ago and now, all of them are enriched with vitamins A and D to help that calcium working and building the bones in women. So that's it. Just most of it environmental factors really rather than genetic. Thank you.
Thank you, Dr. Yazan.
Thank you, Swarno, for having me. And it was a nice talk. Congratulations to all the speakers. My questions goes to Dr. Nazla. Ma'am, you talked about the cycloplegic refraction. So how often do you do this cycloplegic refraction for the child? Like if the child comes for the first time, we do the cycloplegic refraction and you find that the child is myopic. You ask them to wear the glasses, reduce near world, go outside in the sunlight and do outside activities. And you ask them to come back after 3 months. So let's say if after 3 months, the myopic progression is around minus 0.5 diopters or minus 0.75 diopters. Do you recommend to do a cycloplegic refraction at that time also? What is the frequency of doing a cycloplegic refraction, or is there any cutoff limit? Like if there is an increase by -1, then only we are going to do the cycloplegic reduction. Otherwise, we are not going to do that. Your views on that, ma'am?
Yes. In my practice, if I see the patient twice per year, so every 6 months. I see the patient after 3 months in the first visit when I prescribe the glasses. But usually myopic, we follow them every 6 months. So at least I do once per year the cycloplegic refraction. If the patient came in the second visit and in the same year, but I found that there is change in the manifest, I'm suspecting something, there is increase in myopia, I go and do a cycloplegic refraction. I can't hear you.
So increase by minus 0.5, you also suggest to do a cycloplegic refraction.
If it's increased, I always suggest to do checking the axial length for this child and to do a cycloplegic refraction and ask about the patient activities. He's sitting in the front of the iPad for a prolonged. Is he using near activity because it can cause accommodative spasm? So I have to ask about also the myopia in the family. Does the parents are myopic? And to check the axial length, I will check the K reading, check what is the cause of myopia. Is it pathological or?
Okay, thank you.
I would like to ask Ms. Fahima a question. Can we start myopia management on patient undergoing amblyopia therapy?
Of course, I would not see any reason not to start myopia control on a patient going undergoing treatment and amblyopia therapy. So continue the amblyopia therapy. We're not going to stop the amblyopia therapy. We're going to keep an eye on the vision. We're going to make sure that the vision in the good eye is not compromised enough, because if we're doing myopia management, we'd be doing it in both. We would expect to be doing it in both eyes, so they'd be affected the same. So yeah, just keep an eye on the vision, make sure the good eye is not being compromised for any reason.
So how often would you recommend for follow-up who has amblyopia and myopia?
So we tend to do every 3 months.
Thank you.
There is one interesting question from the audience. My question to Dr. Yazan. I'll just read out the questions. So,
Sure.
his query is that, like, a 8-year-old child had in his clinic on August 2021, having a refraction of -1 diopter spherical in the right eye and left eye plano. That is 2 years ago. Then in the March 2022, he came for the follow-up and he got -1.75 in the right eye and left eye -0.50 spherical. Then myopia was prescribed on the last visit because earlier that was not available. And atropine was not prescribed because mother knows child would not cooperate and because of rebound effect if not used continuously. Any thoughts and advice on this case? Child is up to now, before getting myopia, wearing standard glasses and not all the time. Why is the myopia increasing only in the right eye? Just a genetic related or is for any other reason?
Very interesting case. We rarely see myopia developing in one eye, but it happens, and this is a classical textbook case of unilateral myopia. Why does it happen? We really don't know. Genetics do play a role in that. We need to ensure that there are no embryogenic factors. So I would actually refer that patient immediately to an ophthalmologist to ensure that the optical pathway is clear. I'm not sure if they have been referred to an ophthalmologist before going to the optom and prescribing these lenses, but I need to ensure that the signal that goes from to the retina and up to the visual cortex is clear. There are no optical obstacles at all. So if we exclude that and there is no physiological or issues or things that have occurred at birth, then we'll just manage with a myopia control lens, that the one that's prescribed as MyoCare. Also liaise with an orthoptist as well. So maybe we can refer them to Fahima to ensure that the visual acuity between the two eyes, the images that are reaching the retina are equal, so that we will not have an imbalance with that anisomyopia, let's say, and it might cause other issues. So this is a multidisciplinary case, which I really like. So classic, typical, refer them to the ophthalmologist first, ensure that there's no pathologies. If so, keep on working, and of course, refer to the ophthalmologist from time to time. And as Dr. Najla said, they definitely need a cycloplegic refraction. And may I say something? They need a full refraction. I'm not sure if the prescription that was stated there was an undercorrection, a full correction, with cyclo, without. So I need to know more about that. But my advice is full cyclo refraction, especially for this case, to avoid any embryogenic factors. Hope I was able to answer that.
Thank you, Dr. Yazan, for nice explanation. Actually, one of the attendees already asked this question, like, if you want to give the under correction or the full correction. So I think that is also already answered.
Okay, so genetics do play a very important role. I will refer to case, or I will refer to a publication which is done in 2021, who have seen that presence of an APLP2 gene. So they have taken a group having an APLP2 gene, and they have done for 2 hours of study, more than 2 hours of a study, and another group was done who don't have that gene, and they have also done the 2 hours of study or more than 2 hours of study. So the amount of study was equal, and it was seen like the persons or the kids who have an APLP2 gene is more developed, is more prone to develop myopia. So just a question to all the panelists out here and the experts out here. So do you think that in near future, along with the workup of the myopic patients, we need to introduce the genetic counseling for every patient? So that's an open question that anyone can answer. Or you need to do a genetic counseling for any myopic patients coming up to see whether they are more prone, or anything can be done to ascertain that or to reduce that.
I don't think that we need to do it for every patient. It's an expensive, I think, testing. So if there is indication, if you have a high myopic, if you find something on examination, there's a family history, then we can go for it. But for every patient, like half of the patient I'm seeing in the clinic are myopic. So I don't think it is an expensive test. So if there is an indication, I will go for it, sure. But if there is no indication, no, in my opinion.
I have open questions to the speakers. Which is better in myopia management, contact lenses, spectacles, and how we are going to convince the parents, like motivating the parents? It's an open question.
Can we delay that answer till the next stage of our series? We're gonna talk about these. We're gonna talk about all intervention strategies. But just to, the curiosity, any intervention that will not harm the patient and shows good results is good. That's my short answer, in my personal opinion. I'm not sure about Dr. Najla or Fahima, but if it suits the patient and shows good results, then that's the best choice for me.
There is one interesting question from the audience. I think it will go to Fahima or Dr. Yazan also, or Dr. Nazla also. Like, vertical deviation have any effects on myopia progression? Vertical deviation have any effects on myopia progression?
I mean, for now, we don't even know what horizontal deviations have effect on myopia progression. So we can't really answer that question. But as far as we know right now, no.
Okay, thank you, Fahima. Next, we have another question for Dr. Nazla. What age you prefer to start using the cyclopentolate 1% for the child?
So in the American Academy, it is recommended after 6 months, you can start 1% cyclopentolate. But in my practice, I try to be more careful. So I delay it to 9 months to 1 year, especially if the child having a Down syndrome, or the child have a spastic paralysis, or he have any neurological or seizure. I try to be more careful. So if there is no indication, I wait till 9 to 1 year. Before that, we can use the cyclopentolate 0.5.
Thank you. Thank you, Dr. Nazla. Any other question from Mr. Arnav or Mr.
Sorry. I have a question for Ms. Fahima. Like you said about doing an NPC with RF ruler. You do a FC by a measurement, power test, accommodative lag, Any other test you want to recommend, like doing an accommodative facility, or maybe a in PA or emergence facility? Any other test you want to add with this test, or these are the battery tests we need to do every time the patient comes up?
So this was for the basics. So for basics, this is what I would recommend, is just stick to this and just keep going along every time you see the patient, and see if anything is getting affected, anything's changing, and you can then think about, okay, do we need to change the method? Is everything okay? But one very important test that is good is checking the fusional vergence. So we do that by checking the range, the fusion range. So you get a prism bar, check out the base out, base in, see how well a patient is controlling their latent foria. This gives you a bit of an idea as well, and if you're affecting the foria, because sometimes the patient might say, oh, we're noticing that the exophoria is decompensating more at home. In clinic, it kind of looks same. But when you really measure the fusional vergences, look at the control, you get a better idea of how well the patient's control is. Is anything compromising that?
Thank you.
I have one question for Dr. Yazan. That you mentioned in your presentation that role of axial length in myopia progression. And my
Yes.
question is that how can clinician use this information to manage patient in an optical clinic setting? And also, like, which kind of biometry or axial length measurement you would recommend, like as optical or maybe a scan? Both are, I think, it will be difficult for the child. Even the optical, you need to positioning, and axial length also, like a scan also need to position your hand, and according to eye position of the patient also need to change your positioning of the probe. So which kind of
Yeah.
setup you recommend?
That's a very good question. I've been to most of the Gulf countries, including UAE, to both optical stores and ophthalmic clinics. And the sad truth is, we barely have access to slit lamps. So just think about biometry, right? Um, and one of the key factors, as also Dr. Najla said, monitoring axial length measurement is quite important, because it's one of the indicators how myopia is progressing, not just the refractive error component, but we need to correlate between the axial elongation and the increase in the refractive error. So basically, yes, we need to monitor axial length. If you do not have it in your clinic, I think you need to do some co-management, share the resources with the ophthalmic clinics. When I was in the UK almost 20 years ago, we used to do co-management of cataract with ophthalmologists, where they do some of the tests, we do the pre and post-op, and we help each other. And 20 years later here in the Middle East, we need to do that with myopia management. If you can't afford, I know it's not easy at all to buy an optical biometer, refer that child to the clinic once per year to get that axial measurement. If you want to do it, try to do it with a non-contact, like a IOL master. I would love that. A lens star will be fine as well. You will ask me how a 4-year-old child, for example, can sit and just have their head fixed. You can do it. You just need to do some tricks. Like any pediatric ophthalmologist getting their refraction, you just need to do these tricks with the IOL master. Younger than that, well, the idea is there's very few research done on young children, and if we need to do it, we need it with an ultrasound over the lid to minimize contact. I would not recommend under sedation, but if the patient isn't really that cooperative, and if you're not seeing, maybe sometimes a B scan can be good as well, just to give you an indication of what's going on, really. However, if there are no risk factors in the family, and when you do an ophthalmoscopy, you're not seeing any changes going on in the retina, sometimes just relieving them from that stress will be fine. So axial length measurement is more important in children 5, 6 years and over. Younger than that, it's not that crucial, to be honest with you. Doing it with a non-contact optical biometer is the best. And if you don't have it, just talk to your neighbor ophthalmologist, work together. That's it. Thank you.
Thank you, Dr. Yazan. It's nice explanation, and I think you answered everything of my queries. So here I'd like to call Ms. Celine because we have a few questions for MyoCare from our audience.
Celine is here.
Okay, so we have the first question, like we did not see before that ZEISS have a 1.59 index in their stock lenses or even RX lenses, but now it's available in MyoCare lenses. So how it's possible, how you're managing? Over to Celine.
This is true. Actually, this is true. We were not used to have polycarbonate, but we do have it because it's a child lens, and we all know that 1.59 is the safest one. So yeah, now we have it for MyoCare, okay, in 1.59.
Okay, that's great. So my next question to Celine again, as a new special treatment for myopia and especially dealing with children, don't you think that ZEISS should choose who can sell MyoCare lenses and issue like a certificate to have the best possible treatment?
Actually, every optical store who is delivering MyoCare is having a specific training, okay? We think that people working in stores, optometrists, are optometrists, eye care professionals that are themselves already involved into myopia management. And so after doing this training, I think that they are able to deliver MyoCare lenses. We do not want parents to be blocked because the lenses are not available in their city, in their country, wherever they need it, because this is once again a treatment. So yes, we want to be sure that everyone is well trained about the lens and is free to sell it, so that we are sure that at the end, because this is actually the problem, at the end, we have a child and parents looking for the lens. So fully into trainings for them, fully available whenever there is a question. We do trainings about the techniques of the lens, technical training, about myopia, myopic defocus, about everything from myopia management. We explain everything about the fittings, which is actually not that difficult. It's PD and height for an aspheric lens. Then what we need is actually what is needed for every child. You need a very well suited frame, okay, with an eye very well centered, enough high so that the children is not going to go up the frame, very well adjusted so that it's not sliding. So in the training we're doing with this optoms or optician, it's everything. Okay, and Natalie in the region is very well known as well from everyone. So it's going to be delivered and accessible, available in all ZEISS dealer once they have this specific training. So there is a specific training about that. Okay. Then, as you know, the region is wide. We have in UAE, we are direct. In many other countries, we are working with a distributor. So this is why the reason the lens is not available everywhere yet, but it's coming. And in all countries, all optical store will have this training. So it's the same in Lebanon. You will have a specific training. The lens is already available. I'm actually working right now with the Ophthalmology Society. We are going to have a symposium in May with them. So if you have any question, if you need anything, please just let me know. but we want the lens to be available in every ZEISS dealer so that parents will not have to fight. And if it's too complicated, they will not waste the time to find the place to go. And everyone is trained and very well trained to know how to prescribe and fit myopia.
Thank you, Celine. I think our attendees already got their answers. So we have 10 minutes to finish, and I'll take the last question for the panel. And it's the open question. Everybody can, anyone can answer actually. What are the contraindication of prescribing the myocare lens to aphakic eye in children? What are the contraindication of prescribing the myocare lens to aphakic eye in children? Any contraindication?
Is it a question for me?
I think anyone can answer. Dr. Nazla, even Dr. Yazan also can take part, I think.
Can we deconstruct the question a little bit?
Yes.
So you have an aphakic child that had their crystalline lens removed due to an issue, right? And we were not able to implant an IOL.
Yeah,
and
planning
now we
for secondary
have
IOL
to
maybe.
Yeah, basically the patient is now hyperope and he's wearing like probably plus 15. So why are we even prescribing myocare for that patient?
If the child is myope, there is really a problem.
Exactly. Hence the need for the axial length measurement we need, and the retinal assessment. We need to ensure, are they developing myopia? But we're not knowing that because of that hyperopic element, because of the lack of the crystalline lens. So this is a very deep question. I don't think any clinician who has some good decency in their work and some ethics would be involved in that. Let's get the basics first, ensure that the eye growth is right, there are no issues with the retina. Then hopefully we can implant an IOL when the ophthalmologist sees that it's suitable at a certain age. Then we can handle myopia if it is there. That's my personal opinion as a clinician.
I think, yeah, thank you, Dr. Yazan. I think we need more description for these cases so you can answer better actually. Anyway, so here you can finish the panel, and thank you everyone for joining.
I'm sorry, Sven, I just would like to add something because I'm seeing a very interesting question.
Yeah, please take.
I'm sorry. Okay, we are on time. Sure. We are not late. We've got some time, so let's try that one because it's a very interesting topic. The question is there any recommendation to go with both solutions at the same time? Atropine enlarges the pupil vent, annoying vision through the myofit. Okay. I will just reply about the myocare question. In myopia management, we are still trying to find best options. Some child are going to be able to have ortho-K, but a lot of them will not. Some of them will be able to have atropine drops. Some of them not. Some of them will have soft contact lenses. Some of them not. Some will be able to have glasses, optical glasses. Some of them, they don't like glasses. So what I want to say is that right now, there is no one single solution. And you can mix, because even if you're wearing contact lenses, you still need glasses. Even if you have atropine, you still need glasses. And actually, to me, I'm not under a study right now, but there are plenty of studies now mixing solutions, because I think that this is the future of myopia management. So I definitely encourage everyone to mix depending on the profile of your patient and of the myopia management solution available, of course. But yes, this is definitely the future of myopia management. Talking about the size of the pupil, definitely when you talk to myocare, the size of the central zone is between 7 to 9 millimeters. So yes, there is a consequence depending of the size of the pupil. Before going through MyoCare, we tried 12 prototypes, okay, with different types of myopic defocus, different type of distribution in the peripheral zone of myopic defocus, good vision and everything. So you have now two designs, a hard design and a soft design, with two different size of pupils, okay, with age related. This is already something which is really getting precision with the size of the pupil of a child, depending on its age. So we are already focusing on this. So to me, atropine and MyoCare is definitely okay. It's definitely worth it. I know that right now we are doing many eye care professionals are prescribing both, and the results are great. We will talk during workshops actually, but yes, please don't limit yourself. Don't limit yourself with MyoCare. I don't know if everyone want to say something, but
can I add something like atropine, the one you are using, or it will be covered in the next session, so I'm not going into the very details. It's a very low concentration of 0.01%. So that is not going to affect the pupil, and I don't think it will go beyond the myopic area or area of zone. So probably using atropine won't cause much problem along using with the myopic lenses. So yes, because the concentration of atropine is very less. Why this concentration is very less? What is the washout period? Why it has not been used higher? I'm not going to go into details because that will be covered in the next lecture. I'm sure of that. Thank you.
good to know. I think we are done. Aren't we, Swana? We cannot hear you.
Yeah. So we can close the panel, I think. Yeah. So thank you, Dr. Nazla, Mr. Arnab, Ms. Celine, Ms. Fahima, Dr. Yazan, and Ms. Jabin also. So here you can finish the panel and you can proceed for the next. Celine will continue.
I will just finish and share my screen again to talk to you about upcoming events, okay? Here, first of all, if you want to have more information about MyoCare, about events, about publications, studies, about new marketing materials that can help you in your practice, we have a LinkedIn group. Very easy. It's named ZEISS Myopia and Myopia Management. You can ask, request to join, and then we'll allow you to join. Of course, that will be great. So yes, about our webinar series, we just finished the first level, the basic level. We will have 2 other episodes, advanced and experts. Dates are not fixed yet because I'm trying to have all speakers available around the world at the same time with no jet lag and everything. But normally next one should be end of October, beginning of November. Both of them are going to be done before the end of the year. I will give you updates, of course, through the LinkedIn page and my LinkedIn, and even some emails. I have some. What is really important now and is upcoming is the Optoverse Congress. As you know, we are Platinum sponsor. We did not expect at all to go on Optoverse. So that was the extra of the year. But I'm really happy to join. The program is deep, really deep, very interesting, talking to ophthalmologists, optometrists as well. We're going to have workshops, we're going to have speakers from everywhere. So I don't know if you are already registered. If you did not do, please do, because this is a 1 day only and you can earn more than 13 CME points. So it's definitely worth it. What is really interesting here is that it's not going to be a huge congress. It's not APOMEC, so everyone is very accessible. So if you want to share cases, as we had during this webinar, you can come to us, you can come to professionals and directly talk with them in surgery, cataract, refractive, myopia management, anything. So come to this Family First Congress. We will be happy to see you. Thank you, all speakers. Thank you, Swarna. Thank you, UF. Thank you, everyone, for organizing this. And Swarna, I give you the final word. Thank you.
Sure. Thank you, Celine. As Celine already explained, like October 4 will be the first on-site optometry conference in large scale, and in collaboration with the American Society of Ophthalmology, obviously. And this specially designed this unique conference in such a way that you're not going to access only theory, but practical, detailed, hands-on personal training in each workshop, along with the debate session, brainstorm quiz competition, abstract competition, prize distribution with spectacular closing ceremony. And we're immensely thankful to ZEISS Vision Care as the platinum partner for the upcoming event. Thank you, Celine, for your support always. And thanks, Mr. Badouin, also. And optometrists, ophthalmologists all over the globe, and all the eye care professionals, they're joining this Congress. And we're celebrating on the World Sight Day, actually. So let's celebrate and converse together to make this event successful. Support optometry, support eye care. See you in the next webinar on this myopia series, which will be in the month of November or October end. That will be decided later, I think. We'll inform you. And see you in person October 4 conference who already registered. And a simple question to them who did not register yet for the October 4, just think about this one. As an optometrist, if you don't support optometry conference, then who will going to support us, right? Let's think about this one. So that's all for today. Thank you everyone for joining here. And the most important things, you will receive your certificate of attendance and certificate of CME within 20 working days from today. If you have any query, please visit us, our website, https://optoverse.site or www.optoverse.site, and email us at optoversedubai@gmail.com. Thank you for joining. Thanks for the great evening. Good night, everyone.
Thank you, everyone.
Good night. Thank you.
Good night.
Thank you. Bye-bye, everyone. Thank you.
Bye-bye.
Thank you, everyone. Thank you so much.
Bye-bye.